have been part of a task and finish group set up as a part of the London Neonatal Nutrition Group to specifically look at our SCAMP PN guidance. So this is a standardised concentrated PN that's been adopted in London. And we've had quite a lot of engagement from within the London Neonatal Nutrition Group and the wider sort of neonatal community. But in order to sort of really get the project over the line, it's been the four of us. So that's obviously two neonatologists, a dietitian and a pharmacist, just to try and get the guidance into a draft format, which we can then share. So just to give a little bit of background, what we're going to talk about today, we're going to have a little think about why we started using SCAMP in the first place, and then why did we feel at this point that an update was needed. So we're going to have a little look at the evidence base that prompted that. We're going to provide to you a summary of the important changes that we've made and then the sort of the finer detail of those changes. And then obviously we've got hopefully some time for some questions and comments. So I suppose it starts off with sort of saying, you know, we know that neonates are a particular population who need nutrition, not just to maintain their sort of functions, but also they need to grow. And we know that often preterm babies struggle to get adequate nutrition, especially in the early days. So PN was an enormous step forward when it was developed and has led to massively improved survival for this group of babies. So then once we started using PN, I think the next question was why we thought about whether we should be using a standardized concentrated PN. And the reasons for doing so would be that it maximizes the nutrient delivery to minimize early growth failure. It hopefully would enable early delivery of PN in that the formulation is there, it's readily available, and it's easily accessed for any unit. So this is for, you know, a level 2, level 3 units. It should be easy to find. You would hope that by standardizing it would improve consistency in the nutritional care and then also minimize risk of errors in prescribing and compounding. And last but not least, as always, you know, in the NHS, we're looking for things that are cost effective. And there's lots of evidence. I've just put some of the key sort of trials and papers and guidelines that sort of have influenced this decision to use a standardized concentrated PN. The thing that I would say is that ideally that you would use a standardized concentrated PN where there's an evidence base so that it's been tested in a randomized control trial with relevant safety data. And that's what BAPM have recommended. So where did our sort of journey start? So really, this was a response to a national neonatal parenteral nutrition quality improvement, productivity and prevention strategy, so QUIP. And there was a lot of discussion. This was essentially why the London Neonatal Nutrition Group first got started. And we did a lot of sitting and talking and looking at the evidence. And as I'm sure you're all very much aware, there was 2 big trials looking at standardized concentrated regimens in preterm babies, and they were SCAMP. This was the Liverpool-based study. And I've put the references up there. There is also the NEON group, based sort of primarily from the group at Chelsea and Westminster. And there was a feeling that sort of some units were already established in using that kind of PN, and it became clear very early on that it was going to be very difficult to unify London and all the different units and regions to use one regimen. So the decision was made that we would offer both SCAMP and NEON, and people could choose either. I think it's also important to mention there was a couple of outliers. There was somebody who used the East of England regimen, and I think somebody that did their own thing. But primarily, most units opted either for SCAMP or for NEON. And in 2018, the London Neonatal Nutrition Group developed a SCAMP guideline based on the SCAMP study and the Liverpool experience. But I think it's important to say, even right from the very beginning, that it wasn't exactly the same as the intervention arm from the SCAMP trial. One of the main things is the amino acid formulation. SCAMP uses Vaminolact, and we chose to use Primene because it had a longer sort of shelf life and stability, which meant that it was going to be more suitable for all the different units, so that they had a standardized bag that they could keep in stock, that wasn't going to expire quickly, but that then was available for use. So why did we need to sort of revisit this protocol? 7 years, it's not that long, not in the grand scheme of things, but actually there were quite a few things that sort of were cropping up. I mean, the SCAMP trial itself is now over 10 years old. So that's quite a long time in neonatal medicine, and things move fast. There's been quite a lot of new evidence since then, so new trials, and also some new guidelines as well, which I'll talk about on the next slide. I think there's also an awareness that our clinical practice and our neonatal populations are changing quite a lot. We're now resuscitating babies from 22 weeks. So we're looking after populations of babies who are much more preterm than they would have been when the SCAMP trial was first started. Colin Morgan's trial looked at babies between 24 and 28 weeks. We now obviously are looking after babies who are often maybe 22 to 23 weeks. And that changes things slightly. Those babies have a slightly different clinical sort of picture and presentation. There's also been a move towards much earlier enteral feeding, with things like the SIFT trial and the evidence base around enteral feeding. And that's being pushed a lot more. So babies are actually not going on to PN and continuing on it for quite as long as they were before. We do know, and it became very apparent when we looked at different protocols from different units and spoke to people who worked in the different units, that they've been adapting the sort of original SCAMP protocol that was done by the London Nutrition Group. They've been adapting the protocol slightly to suit their populations, or in response to sort of problems that they were encountering with the original sort of guidance. And we know that one of the reasons that you have a standardized bag and a standardized PN regimen is to minimize those differences. So it didn't seem to sort of make sense that sort of there were different units practicing slightly differently. So it was a hope sort of to unify some of that practice again. It was also clear that there was a difference in outcome compared to the other standardized concentrated PN being used in London. Again, I'll come to that in a bit more detail. And we also know that the Liverpool team themselves have adapted the original SCAMP protocol. And certainly, I think as for our last webinar, we had Colin Morgan come and talk about the Liverpool experience and discuss some of the adaptations that they've made in response to the sort of problems they were encountering. One of the things that he talked about in particular was the increased glucose intolerance. And this may be because we're now looking after babies at the more extreme ends of prematurity. It can also be related to other changes in practice, such as the use of prophylactic hydrocortisone, but they were definitely seeing higher insulin requirements and increased glucose intolerance in their population, which meant that they'd adapted their protocol slightly. I think that there's no disputing the fact that it will be lovely to have another randomized control trial. Whether this happens, I don't know. Mm-hmm. So just in terms of the background, these were some of the main things that we were looking at. So we know that ESPGHAN produced guidelines about premature babies and their PN requirements. There was a NICE guideline that came out in 2020, and we've relied on this quite heavily because we felt that we should be falling into line with the national guidance. So we do refer to the NICE guidance quite a lot. There was a big retrospective multi-centre study using data from the UK National Neonatal Research Database that was looking at babies in all different units from 2014 to 2020. This is the paper on the top, done by the team primarily from Chelsea and Westminster. And they were looking at the outcomes following the adoption of standardised concentrated PM. And obviously that's taken into account the fact that they were using these two main types of PN, so the NEON and the SCAMP. And actually, it produced some slightly surprising data in that, unfortunately, what it showed was that morbidity-free survival had actually decreased by about 8.6% after the adoption of standardised PN. And when they looked at that in more detail, it was felt that the adverse difference was higher in the SCAMP group. It's been hypothesized that this could be due to an earlier and higher intake of macronutrients. And it's important that they've noted that there's a slightly higher macronutrient load in the London guideline compared to the original SCAMP trial. And they also picked up again the higher insulin use in SCAMP versus NEON. So again, that's something that prompts us to review our practice and consider whether we need to make changes and alterations. One of the other things I'm going to mention, but not in great detail, is the Prematurity trial. So this was a randomized control trial that was multi-center, that was looking at pediatrics. So it's important to stress that this was a pediatric trial looking at babies, so term babies, to 17 years of age. And it was looking at whether for children and babies admitted to intensive care, you should start PN within 24 hours or delay starting for a week. They did have a reasonably significant number of term babies, so about 145. And so they also did a secondary subgroup analysis to look at that newborn population. And certainly what they found was that for the whole population, the clinical outcome was better for the late introduction of PN group. So there was less infection, so less sepsis, and a shorter ICU stay in the group that didn't introduce PN for the first week. And then in the secondary subgroup analysis, which was published separately to look at the newborn population, that late PN group again showed that the late PN group was clinically superior to the standard care. So certainly Colin Morgan's group in Liverpool reflected this in their sort of adaptation of their guideline, and they have specific sort of information for term infants, especially they categorise them as sick term infants or term infants or infants with conditions like gastroschisis and surgical conditions. And they say that for sick term infants, they advise not giving PN for 72 hours. So these were all things that we had to take into consideration. I think that there's still a lot that we don't know about PN, and I think we can look at specific groups and think about whether we have enough evidence base. So, for instance, this is information in the Prematurity trial about a sick term baby, but how does that differ from a preterm baby? Most of our preterm babies, they're immature, but not necessarily unwell. Obviously, we do get preterms who are also unwell with sepsis or whatever else. How does that affect how they respond to PN? I think the other consideration is, what do we do about the late preterm group? So these are babies that, may often not need PN, but there is a significant number who will need PN. And we know that obviously your numbers in general of this population are much higher. So you get many more sort of 34-weekers than you get 24-weekers. So the population is much bigger, even if all of them don't require PN. You know, when do we stop considering a baby as preterm and consider them as term? I think certainly in Liverpool, their cutoff is about 34 weeks, which is interesting. And, you know, we have to think about all the different sort of variations. There's not the evidence base for every single decision that we make. And I think that that's very important to make that clear. So we felt that there was a case for revising the guideline. And we were quite clear, and it's always been the intention of the London group that we would use the evidence base or national guidance wherever possible, and that we would be guided by that primarily. But, you know, a lot of what we do is not evidence-based, and it's a consensus view, and it's clinical practice. So it was also important to get as much input as we could from the different units that are using the guideline about what they do, how they've changed things, and what they think needs to be changed going forward. I think one of the things when we're developing a guideline to be used by many different units is you don't want to give too much detail. I think it's much better to keep things fairly simple, and it's a guideline, not sort of, you know, it's not enforced, and people can make sort of minimal adaptations, but the key points we wanted to emphasize, but not stray too much into other areas. For instance, I know UCLH has got a beautiful protocol which incorporates their enteral nutrition into their parenteral nutrition into a nutrition guideline. And what we were very clear about was that we didn't want to sort of get into discussions about enteral feeds. Different units do things quite differently, and that wasn't the purpose of the guideline. So it was specifically looking at parenteral nutrition. And we were also very keen that this is for preterm babies. So the SCAMP trial was for preterm babies. That's our evidence base. And we wanted to focus on the preterm. Now, we all know that people use SCAMP for term babies. Everybody knows that. It's in the guideline. And there is information about how you use it for term babies, but it's not something we've gone into great detail about. A whole other work stream is going on in the London Nutrition Group, looking at term babies and thinking about a formulation and a guideline for term babies. So that's a piece of work that's already in process and hopefully will come soon. So we were very much aware that we needed to consider term babies, but it wasn't going to be our focus. I think one of the other things that's important is we have to always think about the formulation. As I said before, we know that already we've strayed away from the sort of specific SCAMP formulation that was used in the original trial because of the change in amino acid. And I think we're getting detail from the Liverpool group about exactly how they've changed their formulation, because our sort of tender is coming up, and we can review our formulation. So again, that's part of the piece of work that we're doing is to review our formulation as well. So the way we did this was we sent out an expression of interest for anybody who wanted to join the group. And we had a large meeting where I gave a bit of background information, such as I've given sort of just now. And we talked a lot about what people's experience was with using SCAMP, and the main problems that they'd encountered with it, or the challenges, and the things that people felt that they wanted to see reflected in an updated guideline. And actually, it was really interesting because I thought there might be a lot of difference in opinion, but actually most units seem to be saying the same sorts of things. And I think that they can be summarized in the main changes that we've made, which is what we've got on the slide. We're going to talk about these in more detail, so I'm not going to go into them specifically, but that sort of these were the themes that were certainly coming out at that initial meeting. So what we did was we took those away. We looked at the evidence base, we looked at the experience of the Liverpool group and the changes that they'd been making and their updated protocol. And We had a task and finish group, which was the 4 of us that we've mentioned at the beginning, because I think it's always difficult to really make good progress with something like this in a large group. I think you often find you need a smaller multidisciplinary group to try and really push through and come up with something that can then go back to the wider group. So we took these changes and the draft protocol back to the original group to sort of say, okay, what does everybody think of this? And there was some really helpful feedback. For instance, the triglyceride monitoring, people sort of like, oh, I'm not really very clear on your table. So we took that away and revised it again. And now that finalized draft protocol with the points and the discussions that we've had sort of at that meeting incorporated, we've put into the draft protocol, and that has gone out. And I'll come back at the end, maybe just to sum up and explain what the process is next. But now I'm going to hand you over to Sian to talk in a little bit more detail. Thank you.
Thank you, Zoe. Hi, everyone. I'm Sian Gaze. I'm the lead pharmacist for medicines and neonatology at the Evelina, and we have been using SCAMP now since 2018 in our neonatal unit. So as Zoe explained, I'm just going to go through the practical changes that we have made both to the aqueous phase and the lipid phase of SCAMP-PN. So starting off with the aqueous phase, those of you who attended the webinar last year probably have some memories of Colin's talk and how they've adapted their SCAMP protocol. So in a similar fashion, we have divided our cohort into 2 groups. So historically, we've always used the same kind of rates and changes in rates for all babies. We're now splitting them into 2 distinct groups based on their gestational age. So there's those babies who are under or equal to 26 weeks and those babies who are over 26 weeks. And from our discussions with other units, it felt like lots of units were already doing this already. They'd already started adapting the guideline, recognizing that perhaps they needed to alter the way they were delivering SCAMP-PN to babies under 26 weeks. So the first change is that the starting rate is now lower. We're going to be starting babies on 50 mils per kilo per day. Previously, we've been starting them on 60 mils per kilo, so it's a lower starting rate. And we're not actually going all the way up to 100 mils per kilo per day anymore. We're going to cap the maximum rate at 90 mils per kilo per day. But we are satisfied that by starting at these rates and by capping at 90 mils per kilo per day, we are still going to be delivering ESPGHAN recommended amounts of nutrition to the patients. And this is similar to what Colin, again, has already done up in Liverpool. We're also going to increment our PN bags slightly slower in our babies under 26 weeks. So you can see from the table there that the babies born at 26 weeks or below will be kept at 50 mils per kilo per day for 48 hours before incrementing up. Whereas the babies born above 26 weeks, we're recommending that they start at 50 and the following day go up to 60. Obviously, this can be dependent on the child in front of you. Like Zoe explained, this isn't rigid, this is guidance, but this is what we think and what we believe will work for the patients. And the other thing to mention as well with the aqueous phase is that the side arms that we are using, there's a slight difference to the original guidance. So the original SCAMP Pan London PN guidance recommended using 10% glucose in all patients. And as Zoe explained, we have recognised within our units and again up in Liverpool that perhaps 10% glucose doesn't suit our smallest cohort of babies. They can often have quite high glucose levels and required to be started on insulin. So a few units already in London had been switching to 5% glucose, and this is what we're now recommending for the whole of London. Babies born under 26 weeks, the side arm ideally should be 5%, and babies over 26 weeks can stick to 10% or switch to 5%, obviously, if they start developing issues. In terms of the lipid phase in the SCAMP regimen, again, obviously they're divided into the 2 groups based on their gestational age, the under 26 weekers and the over 26 weekers. And the main change really is in the starting rate of lipid. So historically, you probably remember we've always started our babies on 6 mils per kilo per day, which is equivalent to 1 gram per kilogram per day. And we're now recommending that we start at 2 grams per kilo per day, which is 12 mils per kilo per day. And we toyed a lot. We had a lot of discussion about the maximum rate and whether it would be possible to go up to 3 or 3.5, 4 grams per kilo per day of lipid as per the Estrogen recommendations. But unfortunately, due to the way our bag is currently formulated, that's just not possible, because at those higher volumes, we would be delivering too much in terms of the vitamins. So we're going to remain at 17 mils per kilogram per day, same as before in terms of our maximum rate. As you can see again from the table on the slide, the increment is slightly slower in the 26 weekers and below. So they will remain on 2 grams per kilo per day or 12 mils per kilo per day for 3 days from the initiation of PN, whereas the slightly older babies will go up after 48 hours. And what we recognise is that by adjusting the aqueous and the lipid rates, we shall now be delivering a better protein to calorie ratio. So one of the theories behind, well, why are our babies developing hyperuremia early on? Why are the little ones not tolerating it as well? The feeling was that perhaps we weren't getting the protein calorie ratio correct. And by delivering more fat to protein ratio early on, that energy ratio should be better on this new regimen. I'm not an expert on protein calorie ratios, but I'm sure Kate can explain a little bit further. And she is going to take on the presentation from here. So I'm going to hand over to Kate now.
Thanks very much, Sian. Can you hear me okay?
Yes, we can.
I must apologise that my camera was working initially and it appears to have failed me. So I'm very sorry about that. But thank you, Sian. I'm Kate. I'm a dietitian at King's College Hospital, and similar to Sian, have been using the SCAMP regimen since 2018. As Zoe was saying, we've looked at what we might do with our sick term infants, and we've revised some of the guidance accordingly. As we know, SCAMP parenteral nutrition, the formulation is designed for use in preterm infants. But we do recognise that in the absence of a standard bag for term infants, that SCAMP is used in a small number of term infants on neonatal units, particularly those who have surgical babies. On the right-hand side, you can see there that we've got some advice about incrementing for term infants according to the greater than 26-week protocol, but to cap the total infusion of SCAMP aqueous PN to 75 mils per kilo per day to avoid over-infusion of carbohydrate and protein and other micronutrients. We've added in some detail about sick term infants and to delay the initiation of PN in these infants for 48 to 72 hours to avoid potential consequences of overfeeding in critical illness. As Zoe was saying, these infants who are suffering critical illness like septic shock, multi-organ failure, suffer acute metabolic stress, and certainly in this situation of catabolism, they don't undergo any normal growth, and so ultimately overfeeding is a real risk for this population. And the reason why we've chosen 48 to 72 hours is that is the recommendation from Estrogen on the management of critically ill neonates, and there's the reference there from 2021. So we're going to recommend that we delay PN in sick term infants, and where we do use SCAMP, we should be capping it at 75 mils per kilo per day. And of note, when we cap it at 75 mils per kilo per day, we also give a reduced amount of electrolytes, micronutrients, vitamins, minerals, and therefore we should only be using it for 2 weeks in total, SCAMP, and before moving over to a more bespoke regimen. The majority of these infants are likely to be in a tertiary centre, which hopefully has access to bespoke PN, and so we believe that that's an achievable goal. Moving on to grading of enteral nutrition, just to highlight the previous guideline. The previous guideline recommended that as enteral feeds are increased, we've initially reduced the supplementary glucose, then the maintenance aqueous, and that we halve the lipids when we reach 100 and we stop lipids when we reach 120. Now, one of the drawbacks to this is that we get a disproportionate amount of lipid during the weaning onto enteral nutrition. And just as an example here, if we have an infant on 150 mils per kilo per day, there are 90 mils per kilo of enteral feed, according to this guideline, we would still be on 17 mils per kilo of lipid and only 43 of scamp aqueous, which is not in proportion as according to NICE guidance. So the revision that we have proposed is that we would reduce supplementary glucose and aqueous as steps 1 and 2 the same, but we would reduce lipid to 12 mils per kilo when feeds reach 50 mils per kilo, and reduce to 6 mils per kilo of lipid when feeds reach 100 mils per kilo. And we would stop again, that hasn't changed, when we would stop at when we reach 120 mils per kilo. Now, just go back over. Thank you very much. Thanks, Zoe. We recognise really, and Zoe's already highlighted this, that this is a parenteral nutrition guidance. We aren't giving advice on enteral nutrition, and indeed many units will have very different enteral feeding protocols. So I think certainly the grading to enteral nutrition, it's really important that people use this guideline alongside their enteral feeding guidance. Can you turn on to the next slide, Zoe? Thank you. So again, in the previous guideline, there was also some guidance on smaller infants, that when we get to 100 mils per kilo of enteral feeds, then the total fluid intake can be increased to 180, but some acknowledgement that that only applies to infants on breast milk and not on preterm formula. Now, there's an acknowledgement generally that infants on breast milk fortifier are often started on breast milk fortifier at an earlier stage than they used to do, and whilst still on PN, this can lead to excessive macronutrient intake. So we've given a little bit more advice on how to manage these infants. So we've kept that we can increase enteral feeds, total fluids up to 180 if we're feeding unfortified breast milk when that exceeds 100 mils per kilo. But that should be individual patient consideration depending on whether they can cope with that higher total fluid intake. But a very key point here is that if an infant is on fortified breast milk or they're on preterm formula, then that must be capped at 150. And of course, some units may be using half-strength fortifier or full-strength fortifier. Indeed, if you have to give full-strength fortifier to these infants when they're still on PN, and certainly some of the higher protein preterm formulas, then even 150 may indeed be a little too much. So I think it's really important that people do look at this parenteral nutrition guidance alongside their own local enteral feeding guideline. Now, just moving on to the triglycerides. As Zoe said, there was some confusion really around when to reduce and when to stop triglycerides, and so this table hopefully will help clear that up. We have a sort of a RAG rating, a red, amber, green, of what to do dependent on the infusion rate of the lipid and also the triglyceride level. The previous cutoff was 2.8 millimoles per litre, but this has been revised to 3. It's only a small change, but it is revised to meet the ESPCAN guidance from 2018. There's also some in those guidance a highlight that 9 mils per kilo of phospholipid is required to meet essential fatty acid requirement, and a recommendation that we don't infuse below 6 mils per kilo in order to maintain these essential fats. To avoid stopping for more than 24 to 48 hours, certainly to repeat in 24 hours. And if we stop for longer than 48 hours, we do need to be thinking about the provision of vitamins. And I hope that this RAG rating does help. Essentially, if it's less than 3, we will increment per protocol or remain on full lipid. If it's between 3 and 3.4, we tend the general guidance is that we should hold at whatever rate is running of the lipid. And between 3.4 and 4, we would recommend that we decrease by 1 step. And if it's greater than 4, either stop it if they're on a very small amount of lipid or reduce down to the 6 mils per kilo. So hopefully that is a little bit clearer and will help people in clinical practice. And I'm going to hand over to Priya.
Hello, good afternoon. I'm Dr. Takir Fatima, neonatal consultant at St. George's Hospital, and I'll be talking about uremia and hyperchloremia in the context of SCAMP. continuing the theme of our working group, I didn't want to be very prescriptive about urea management per se, but to get the team, get people thinking broadly the context of how to interpret urea result in terms of holistic nutrition management. So generally babies who are on PN, they have a repeat biochemical monitoring, and poor urea in the context gets the exclusive biochemical blame in the sense that the reflex reaction is to address the protein load for the baby. And what I just wanted the teams to do was to think a little bit more holistically in terms of managing babies with a raised urea. And also it's important that we just don't get react to a single value and general look at the general trends of this result as well, which is quite important. So at least 4 key important factors, with the first being the common things first would be, yes, raised urea in the context of a raised creatinine level, and then again looking at other aspects around the baby in the context of reduced urine output. Definitely there is renal function compromised, definitely to reduce the protein load, so to come down on the aqueous PN is what we would imply. But there might be other things in the context of a raised urea is the questions like, is this baby just definitely protein overloaded, or there are other things that are that need addressing in the context that the total volume of fluid that this baby is getting, so are they dehydrated, and hence why there is a raised urea. And additionally also to look at other things that this baby might be receiving, like are they on have they been recently commenced on steroids? Are they on diuretics? Are they on any NSAIDs as a part of duct management as well? So, or on any nephrotoxic antibiotics like gentamicin. So just to have an oversight of medications as well. And the other key thing that is a part of the whole change in our SCAMP guideline is this baby getting enough calories? There might be instances where the team might have reacted to, say, a raised triglyceride level, have come down on the lipids, or have responded to raised blood sugars and come down on the glucose carbohydrate delivery, and therefore this baby is actually not getting enough calories and has therefore started oxidizing amino acids for energy, causing a raise in urea levels. So definitely all these factors are important. And in this instance, in the last instance, you would need to give this baby more calories rather than come down on the PN per se. So another important thing that I just wanted to mention is to look at the physiological journey of the baby. So within the first few weeks of life, there might be a difference within how the baby has tolerated the protein load because they are still adapting physiologically in terms of their renal function and their liver function as well. And slightly later on, like from the second, third, and fourth week onwards, there is more maturity and there has been more adaptation. So they might take on to the protein and amino acid load better. Next slide, please. Sorry, I've gone back just the slide before, yeah. So therefore, the key message is to optimize hydration, review medication, and reduce aqueous PN only in the context of that you've demonstrated that there is renal dysfunction. We have recommended that not to go below 35 mL per kilo per day in terms of SCAMP. And if at all you're persistently in that territory and not able to optimize, then the recommendation would be to look into going into bespoke PN if you're looking at values of SCAMP below the 35 mL per kilo per day. And then to definitely keep an eye on the urea, creatinine, and fluid balance for babies while they're on PN. Next slide, please. Similarly with hyperchloremia and metabolic acidosis, It's key that we not solely don't look at the chloride within SCAMP per se, and because that's generally a default go-to. The moment there is a raised chloride, it's on the gas list, it usually gets circled and people start looking at the SCAMP, and it's actually to take a step back and look at all the other chloride sources for this baby. So this baby might be for the very small babies, the small flushes of saline that they are getting are adding to their chloride load. There might be arterial lines, which are again contributing to the chloride load as well. So not to look around at other input sources. And then if at all there is persistent worsening hyperchloremia, then that it can be addressed within SCAMP by going on to bespoke, but just to be mindful that the chloride delivery within SCAMP within the first few days is actually quite minimal. Hence why SCAMP might not be the best and the only mode of changing chloride. And the other thing that we usually see is that there is a lag after hyperchloremia. You see that there is a metabolic acidosis, which is seen as a late effect of hyperchloremia. There is still lots of, it's an evidence poor area in terms of chloride management within neonates. We've got the nice recommendations, but definitely there is room for more research on this side. That's my slides.
Thank you, Tukir. So just to summarize, I mean, we've given you a very, very quick whistle-stop tour through the main changes and the rationale for those. We've now, the draft guideline is out for consultation with the rest of the London Neonatal Nutrition Group, and we will obviously take all those sort of comments and queries into account. Once that guideline is then finalised, it will go to the ODNs for review and then ratification in the overall sort of London group. Obviously, with any kind of change to a guideline, there would need to be a programme of education prior to implementation. And I think it will also be extremely important in the absence of those sort of randomised control trials and things like that, that we do some prospective audit and monitor to see what the effects are of the changes that we make. We are very happy. I think we've talked for a reasonably long time, but hopefully we've got some time for some brief questions. I have included all the references, but I won't dwell on them. I will. I'm happy to share the slides. I'm sure Mo can arrange that. I'm going to stop sharing so that you can address your questions to everybody.
Thank you so much, Zoe, Sian, Kate and Talkir. That was really, really, yeah, the amount of work that's gone into that is really impressive. So thank you for doing that on behalf of the LNNG. And yeah, the floor is open for questions. If people want to add any questions into the Q&A, please do. While people are thinking, because I can't see any questions at the moment, I wanted to ask, it's been mentioned a couple of times about the protein energy or the protein calorie ratio. And I wondered if any of that information will be added to the guideline as well, so people can clearly see what we should be aiming for with these preterm infants and how that will be met as the PN sort of increments up or changes.
I'm going to turf that one to either Sian or Kate.
Do you want me to?
Yeah, do you want to go, Kate? You can explain what we've done.
Fine. So on the actual the main part of the guideline, we've put a table with some details on the amount of energy per gram of amino acid, and the recommendation from NICE is that should be between 20 and 30 calories per gram of amino acids. So we have put that in, and pretty much at all stages of increments, but with regard, if you keep the aqueous and the lipid in the same proportions according to the guidance, it's around 20 calories per gram of amino acid, which of course is at the lower end of the ideal range. But one of the reasons, as Sian said earlier on, that we recommended giving 2 grams of lipid was if we actually only gave 1 gram of lipid very early on, that number reduced to 15 calories per gram of amino acid. So it falls out of the range that's ideal from recommendations from NICE, hence the reason why we went to 2 as a starting point of lipid. We have added that into the guideline, and I guess if anyone has any more comments about any more clarity that they would like putting into the guideline and adding to the guideline, then yes, sort of, you know, ideas on a postcard, please. You know, if anybody wants some more clarity, then we can certainly provide that. But we have put a little bit more information into the guideline at the first revision.
Yeah, for those who are familiar with the current or the previous draft of the guidance, you'll probably recognise there's a table which says if you're on 60 mils per kilo per day, you'll be getting this much nitrogen, this much carbs, this much sodium, blah, 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 all the electrolytes. That's where we've added the extra column explaining the protein to energy ratio. So we've just readapted that table with a slightly different, you know, starting at 50, 50, 60, 70, 80, 90, and just explain then the energy to protein ratio in one of the columns.
Thank you both. Still no questions, although Venetia has said great presentation. Thank you, Venetia. I absolutely agree. Another question then, what people are still thinking, around, so you mentioned at the end that obviously we're going to have to think about how this is disseminated and the training and education piece. I wasn't in post or even in the country when that sort of process happened with the first iteration of the guideline, and I wondered if you all had any sort of initial thoughts, or maybe even people who are watching, if you have any thoughts or feedback on how you think would be best to sort of disseminate and support units with changing and the education piece, essentially. Questions? Go ahead, sorry.
I mean, I was part of the group that did the initial guideline, and I was working at the Homerton at the time. So I actually was working on a unit that did use SCAMP, unlike now. And I think the thing I would say is that everybody, I thought, dealt really, really well with the initial sort of introduction of SCAMP and the standardized PN, and that was a big step. And I know certainly at the Homerton we did quite a lot of education around it and things like that. I would hope that this is a smaller step because people are using it. They may even be using it in a way that's fairly similar to our new guideline. So hopefully it won't be such a big change. It will need some education, but hopefully these are smaller sort of tweaks rather than sort of a huge step change.
Great, thank you.
That was going to be one of my questions, actually, is really whether anybody's got any concerns or any worries about making these small tweaks. You know, can anybody identify reasons why they might find it difficult to make these small tweaks? Because I think, as you said, Zoe, when this guideline was first launched, from memory, I think we all did individualized education within our units. And in my head, I guess I was foreseeing all that again. But does anybody have any worries or any concerns about doing that? Or is there anything else we can do to support you with that as a group?
Yeah, that's a really, really good point, Sian. And, you know, certainly if there's anything that we, the nutrition group or the ODN as a whole can do to facilitate that, that'd be really important. So hopefully that people will be thinking about that. There are a couple of questions now. So the first one is from Monica Lee. She says, will there be consideration of higher accepted triglycerides when patients are on more than trophic enteral feeds, or the same guidance whether or not the patients are not on enteral feeds?
Who wants to go with that one?
Yeah.
My understanding would be regardless of enteral feeds, the guideline applies. The recommendations would be the same. I don't know if anybody else disagrees.
Yeah, I would agree with you.
Yes, I would too. And I think particularly when we're getting on to increased volumes of enteral feeds, that it becomes less and less important to monitor triglycerides at all. The evidence base for triglyceride cutoffs is very poor, and I think it can mean that people are very reactionary potentially and reduce nutritional delivery, whether that's enteral or parenteral. So I think we need to be a little bit careful that we don't get too overzealous with triglyceride monitoring, particularly if they're on a lot of enteral nutrition.
Thank you. We have another question from Claire Kane. She says, your advice around urea is helpful. Is there an absolute maximum that you would accept before reducing PN if the creatinine is normal and hydration or drugs are taken into account? It always feels uncomfortable to have a urea of 10 or more.
I mean, I'll let Tukir answer it. Yeah.
Yeah. So again, so we've kept it as a range between 8 to 10. But then again, there is definitely other parameters that you will have to take into account, which we talked about. So if you have a definite base as to why this baby has a slightly raised urea in the context that, okay, they're getting diuretics or steroids, but the overall picture of this baby is fairly stable, then you can monitor and like have a safe overview of this baby. Say you are on a urea of 10 or 11 on the higher end. It would be important to monitor it more frequently, but then otherwise accept if the rest of the renal function is okay. I don't want to become too prescriptive about this because it is tricky, because each individual scenario would be different. It might be different in the context of a severely growth restricted baby who's having, say, like refeeding syndrome and other things as well. So it is very difficult.
I think certainly speaking to some colleagues in the tertiary units, especially, they felt reasonably comfortable sort of with the higher end of the sort of range. But again, as Tukir says, I guess it just depends on the individual.
And I think from speaking from our experience at the Evelina, I just find that if you just slightly hold your nerve a little bit with these babies and don't react too much, give it a couple of hours, give it a day or so, the urea will generally naturally start to drop anyway. I mean, obviously, if the urea is increasing, then you probably want to intervene. But I think sometimes it's just about being patient and just letting the baby stabilize a lot of the time. And that generally seems to do the job.
Come on in, Kate.
Hello, sorry, it's very distracting not having a camera. I'm ever so sorry. I would very much say that fluid balance is very, very important in these infants. We are giving SCAMP is inherently higher in protein, and protein is part of the picture, but hydration status is really, really important. And I think sometimes there's a risk that we get a little bit behind with fluids with these infants quite early on. So keeping on top of fluid balance. Everyone's fluid management, I think, is different according to from one unit to another, but I think it's just important to highlight that is potentially a very significant part of the picture in these babies.
Thank you. We had somebody who is using Neon PN, and they say their starting rate for their acris and lipid they think is the same, so that's useful to know. And then we have, this will probably be our last question before we have a small break, from Carolina Zorro. PN on day 1 will be 62 mils per kilo per day, so that's 50 of aqueous and 12 of lipids. For extreme preterm with other infusions and a UAC, PN might need to be reduced if total fluids can't be liprolized. Would you reduce aqueous or lipids or both?
I think personally we wouldn't reduce either. We currently would give 66 to these babies because we give them 60 of aqueous and 6 of lipid. That's our current protocol. And we would add on personally in our unit the other infusions. We don't deduct the arterial fluids, for example, from our total generally. That's not the practice. We haven't included any guidance on this in our guideline because I guess it probably does vary from unit to unit, but personally my advice would be leave it as it is. Otherwise you're going to be decreasing the energy that the baby's receiving. You're not going to be meeting the recommendations for their nutrition. But I'll let others comment as well.
Yeah, the micronutrients as well.
Yeah, I think I would echo that. I think
it's not really that different to what we're currently doing, 66, 62. It's the same ballpark really. Just a different proportion of lipid to aqueous phase.
Hey, great. Thank you all so much for presenting, and thank you for everyone who contributed to the Q&A. Really, really interesting questions. Yes, we can.
Yes.
Yeah. Great. Yeah, thanks, Zoe, for that introduction, and for highlighting the BAPM framework being due. I'll come on to that and hopefully give some updates. So just to mention, so I gave kind of a similar talk about a year ago at N3. So people that were there, this might sound eerily familiar apart from the odd update here and there. And I always put up this disclosure slide when I'm speaking to primarily a neonatal audience that I'm not a neonatologist. So actually the majority of you, neonatal doctors, nurses, dietitians, pharmacists, etc., do kind of manage this on the shop floor much more than I do, but hopefully kind of I can give an endocrine insight into the basis of this condition. So I'll talk briefly about the etiology. In the past, I've kind of spoken a lot about calcium and phosphate homeostasis, that hopefully people are aware of that now. So I'll touch on that briefly and then spend most of the talk about the BAPM framework messages in the domains of prevention, screening and treatment. And then if we have time at the end, talk briefly about why it's important and what the framework highlighted are significant gaps in evidence that would form a future research agenda, particularly for people that are trying to start up some studies in the area. So I do always tend to talk about terminology, especially when people are kind of doing a literature search on the condition. And essentially, metabolic bone disease of prematurity refers to, quite simply, an undermineralization of the preterm skeleton. Now, historically, you will see terms such as osteopenia of prematurity, which is more a radiological label where you have a washed out appearance on radiographs, although this can be subjective, and very old studies have shown that you need about 30% bone loss before you can visually appreciate osteopenia on radiographs. And then the other term that's often used is rickets of prematurity, and this refers to the typical biochemistry that one sees in metabolic bone disease of prematurity, that being a low phosphate, which is common to all forms of rickets, not just in prematurity, but when we talk about nutritional rickets, when we talk about hypophosphatemic rickets due to XLH, etc., all of them are characterized by a low phosphate, and that causes some of the clinical features. And because of the low phosphate, you get increased attempts to mineralize the bone with a raised ALP, plus or minus a raised PTH, and we'll come on to that. And then you get the typical radiological features of rickets. So this is a child with metabolic bone disease of prematurity. You can see the washed out appearance here, typical of osteopenia. And then you can see the features of rickets, the cupping and fraying of the ends there. Here you can also see the features of raised PTH, which is that you get this periosteal cloaking to the bone. But the kind of all-encompassing term that's preferred now is metabolic bone disease of prematurity. So in terms of the cause, before I talk about calcium and phosphate, I think there's more and more recognition from the clinical cases that we encounter, rather than anything in the literature, that there is a role for the fact that these preterm babies have incomplete ossification. And so that speaks to the fact that the scaffolding of the bones into which the calcium and phosphorus go into is not completely there. And I think that speaks to the importance of good protein provision for these infants beyond just calcium and phosphorus, particularly in the extremely preterm infants. So here you have that kind of deposition of osteoid that actually is lacking in the first place in the really preterm infants. And then that osteoid is mineralized with calcium and phosphorus to cause mineralized bone. Because after that ossification step, you then get a mineral deficiency in preterm infants because not enough calcium and phosphorus is going in. And that's because by far the majority of mineral accretion into the bones happens in the third trimester. So if you're born preterm, you miss out on massive amounts of calcium and phosphorus going in. And the reason why that's important is because that third trimester is a period of rapid bone growth even postnatally once they're born, there is a period of rapid bone growth, and so your requirements for calcium and phosphorus are much higher. And unfortunately, despite all the advances in postnatal feeding regimes, we can never replicate what the placenta would have been providing. And then in addition, preterm babies have various risk factors that further increase the risk of generating a calcium and phosphorus deficiency for the bones. So if we think about homeostasis in physiology, if there is a calcium deficiency in the body, i.e. not enough calcium is getting in, then there are two main hormones that respond. The first is 1,25-dihydroxyvitamin D. So this is the active form of vitamin D. It's produced by 1-alpha hydroxylation of 25-hydroxyvitamin D, which is what you measure when you measure serum vitamin D. And then that acts on the gut to increase the absorption of both calcium and phosphorus, and therefore increases calcium levels. The other hormone that's even more key is parathyroid hormone. So that increases 1-alpha hydroxylase activity, so indirectly increases calcium and phosphorus absorption from the gut. It also acts on the bones to mobilize calcium and phosphate from the bones. So both of these would cause an increase in the serum calcium, but would also cause an increase in the serum phosphate. And if that was left unchecked, these two would simply bind together and the ionized calcium would still remain low. However, in the kidneys, as well as increasing calcium reabsorption, it actually causes phosphorus excretion. So that the net effect, even in the context of a calcium deficiency, is that the PTH works to keep your serum calcium normal, but at the expense of phosphate. And that's why even if you are calcium deficient, you will end up seeing a low phosphate in the blood tests, which is important to recognize that it is not just reflective of a phosphate deficiency. And then, as with all endocrine systems, there is a feedback loop via the calcium sensing receptor in the parathyroid glands to keep your serum calcium level normal. On the other hand, if you have a dietary phosphate deficiency or a phosphate deficiency of other sorts, the homeostatic mechanisms are not as well defined and robust. So in the gut, the absorption of phosphate is mainly passive. There is an active element from the 1,25-dihydroxyvitamin D that we've mentioned. And then actually most of the homeostasis occurs by regulating urinary excretion. We've heard that PTH causes urinary phosphate excretion, as does FGF23, which is a hormone that's released from the bones. But importantly, there is no phosphate sensor per se, like there is a calcium sensor, and certainly not an active one in the parathyroid glands. Therefore, if you just have a phosphate deficiency without a concurrent calcium deficiency, then your PTH will be normal. And this alludes to the fact that the PTH is really important in differentiating what is causing the metabolic bone disease of prematurity. I would argue, both from like clinical practice and physiologically and pathophysiologically, that phosphate deficiency may be less likely than a calcium deficiency, because there is good evidence to show that in preterm neonates, about 80 to 90% of the phosphorus that's in feeds is absorbed, whereas only about 60% of calcium is absorbed. So that kind of gives a pathophysiological basis to some of the recommendations we've given in the BAPM framework. So the aim of this, when I approached BAPM, was to try and harmonize broad practice across the UK. And actually doing the BAPM framework has made me realize even more just how much variability there is across the country with regards, prevention, screening, treatment, all of those aspects. And we thought it would be useful to harmonize that so that there is consistent practice across the UK based on whatever evidence there is available, and there are gaps in that, and if not, then based on consensus of a multitude of healthcare professionals. So we did literature searches and we made recommendations graded according to the quality and strength of the literature backing it up. So we had a working group including members from BAPM, consultants, trainees, nurse practitioner, physiotherapist, members from the neonatal dietetic interest group, neonatal and pediatric pharmacy group, biochemists, because a lot of the screening is reliant on biochemistry, pediatric endocrinology from the British Pediatric and Adolescent Bone Group, and we had a parent representative for some of the parent information that we have created as part of this framework. This has been in creation since January 2024, and it will be due out for consultation soon, but I say that with fingers crossed because I've said that a few times already. There has been a bit of back and forth between BAPM and the working group as we try and kind of iron out certain issues, a lot of it to do with the length of the framework, because we really wanted to have readers understand why we have put forward the recommendations that we have, so that people understand our thought process rather than just the statements that are being made. But obviously that does increase the length. So there have been discussions that are being had, and hopefully we're in the final stretch now. So if I take some of the kind of key points from that, and I'll divide it into prevention, screening, and treatment. So in terms of risk factors that we need to focus in on babies that you want to prevent the development of metabolic bone disease of prematurity, there is really good evidence. This is from a meta-analysis that birth weight and gestational age are the two biggest risk factors, birth weight even more so than gestational age, in the development of metabolic bone disease of prematurity, closely followed by a prolonged duration of PN. And we define that to be greater than 4 weeks. And I think we can all understand why that would be. The more preterm you are, the less calcium and phosphorus has already gone into your bones. The birth weight, whilst also related to gestation, is also in itself a risk factor for potential placental insufficiency, so that the time that baby was inside mother, the delivery of calcium and phosphorus may not have been optimal, and a prolonged duration of PN because there are limitations in how much calcium and phosphorus PN can give compared to enteral feeds. Then some risk factors that did not come out as high in terms of strength were the use of diuretics, and that's important because it causes calcium excretion from the body, and prolonged and recurrent use of steroids, which limits the calcium absorption from the gut, whilst also directly affecting bone health. Some studies have suggested that ranitidine, caffeine, neck, and chronic lung disease are risk factors, but there was insufficient evidence to recommend these as primary risk factors in the framework. Now, I think a key part of preventing metabolic bone disease of prematurity is to optimize nutrition as far as possible, rather than going straight down the route of supplementation. And so there is a big focus on that in the framework, particularly in either fortifying breast milk or using preterm specific milk formulas, so that there is enough calcium and phosphorus going into the baby to try and reduce the risk of metabolic bone disease of prematurity developing. And an important part of that is to try and maintain ratios, which I'll come on to, even in PN, to try and maintain a calcium to phosphate molar ratio of 1.3 to 1 when prolonged PN is required. In practice, we recognize that this can be challenging depending on local provisions of bespoke PN and stability of calcium and phosphate concentrations, but this is the ideal that we are aspiring to. And then preventing vitamin D deficiency by routine vitamin D supplementation. So if we talk a bit more about nutritional management, you can see that the amount of calcium and phosphorus in unfortified EBM, if you think about how much was going in per day in the third trimester, is very inadequate. And if you compare that to fortified EBM or preterm formula, there is much more calcium and phosphorus, and therefore you're trying to avoid the calcium and phosphorus deficiency that drives metabolic bone disease of prematurity. And this is roughly in line with the American and European guidance. Again, like we've said, the ratio of calcium to phosphorus is important. And on a molar basis, that's about 1.2 to 1.3 to 1. And that's because studies from the 80s and 90s have shown that this ratio of calcium and phosphorus allows optimal gut absorption of calcium and phosphorus, and therefore again, that ratio tries to prevent the development of metabolic bone disease of prematurity. On that third row in this table, you can see that vitamin D supplementation is recommended in both American and European guidance. And although the evidence for this is unclear as to how much of a benefit this has, in the absence of harm, we have suggested giving vitamin D supplementation because it tends to be quite common. In a study done by Oxford, almost 90% of their preterm or very low birth weight infants were vitamin D insufficient or deficient. So I'll just quickly go through the handling side of things. We wanted to do that for a couple of reasons. One, to make units aware of trying to avoid the complications that come of metabolic bone disease of prematurity. Because if you don't recognize that these bones might be weak because of their calcium and phosphorus deficiency, then you increase the risk of fractures and distress for the infant. So we've discussed, particularly in our parent information leaflet, the importance of positioning and handling safely with splayed hands, with nesting, and trying to avoid pressure points when you're undertaking nappy changes, dressing, medical procedures, and to consider, especially if the metabolic bone disease of prematurity is marked, using a second person for such procedures. So trying to avoid kind of pincer grips and pulling of arms and legs to reduce the risk of fractures in those that already have metabolic bone disease of prematurity. And like I've said, it's a big focus of the information sheet that we've designed. The other thing to look at, because there's a lot of research being done on this internationally, not as much in the UK, is whether actually there is a role for physical activity regimens to help actually treat or improve the bone health of preterm infants. And this is based on the mechanostat theory that says that one of the biggest determinants of bone health across life course, not just in preterm infants, are the muscle forces that are applied to it. And this makes sense in the context of metabolic bone disease of prematurity as a risk factor, because in mum's womb, a baby is kind of pushing and kicking against the womb wall, so utilizing the muscle forces so that the bone is adapting and becoming stronger, whereas postnatally, they just lie on the incubator without much muscle stimulation. And so we did want to have a look at what the evidence is about passive physical activity regimens. Now, we found that there's quite a few systematic reviews that have suggested an improvement in bone turnover markers and in short-term bone density, but there's actually no data on long-term bone density, on whether it improves fracture rates, which is kind of important from a physical activity perspective, or anything to correlate whether it improves the biochemistry that one would typically look at when one is diagnosing metabolic bone disease of prematurity. So although that's an area that we highlighted as research, we've currently advised not to pursue it, especially as I've learned from the BAPM framework that there is some evidence that it disrupts neurodevelopment as well, the passive physical activity regimens. And coming on to screening, in terms of timing, we agreed as a group that it shouldn't be done any earlier than 2 to 3 weeks of postnatal life, because there can be initial changes to calcium and phosphate levels that are unrelated to metabolic bone disease of prematurity. And we've stressed the importance of only starting to undertake screening once enteral nutrition is optimized, because we recognized as a group that there is the risk of going down the pathway of starting supplements, etc., when actually we need to focus on optimizing nutrition, making sure EBM is fortified, etc., and not adding an osmotic load of supplementation unnecessarily. And the group came to a consensus decision of doing the screening fortnightly. There is no evidence anywhere that suggests that weekly, fortnightly, anything is better than the other. In terms of the biochemistry, I think one of the key points that's important to recognize is that although we've given cutoffs, it's important to kind of talk to your local labs about what their reference ranges are and how robust they are for the age group that we are talking about, i.e. preterm infants. Then we looked at ALP, which is traditionally kind of used as the commonest marker of metabolic bone disease of prematurity. And there were lots of studies ranging from 500 to about 900. But the best quality evidence was from this study by Lee et al., saying that at 650, there was the best compromise between sensitivity and specificity. Phosphate, the evidence was for less than 1.8 millimoles per liter, but this is really important for appreciating that your lab has a local neonatal age-specific reference range so that you're not missing out on hypophosphatemia because slightly older reference ranges are applied. And then I think an important thing that we were keen to stress in the working group is the use of PTH as a screening tool. I know lots of places are doing this already, but there are some that would then measure the PTH if the ALP or phosphate was deranged. I've not put the figure on here, but again, the Oxford group have done some work to show that there is quite a big chunk of infants that actually that first present with changes in PTH, which may not have abnormalities at that time in ALP or phosphate. And so you might be missing an early marker of treating metabolic bone disease of prematurity. The cutoff that we chose, there was some debate. Typically, most reference ranges for PTH will say that anything above 7 is elevated. And in the absence of any good neonatal reference data, we have always advised that as well. But actually, last year, there was a really important paper that looked at reference ranges of PTH in preterm infants. And you can see that the reference range is actually higher in preterm infants, actually up to about 12. And this is fairly reflective of work that's now been published by Oxford last year or beginning of this year that showed that when they adjusted their cutoffs to 12, they actually showed similar outcomes to when they were using cutoffs of 7. Pragmatically, we've chosen 10 because a change from 7 to 12 is quite a big jump and we may be missing cases. We've stressed the importance of using a combination of these biochemical markers rather than just relying on one alone, and there is evidence to say that that improves the accuracy. And the role of 25-hydroxyvitamin D is not in the diagnosis or screening of metabolic bone disease of prematurity. So it's more to identify things that can help improve the bone health rather than to screen for metabolic bone disease of prematurity. We've already shown on a previous slide that actually vitamin D deficiency is very common, but that doesn't necessarily mean that the child has metabolic bone disease of prematurity. There has been some studies on the use of urinary markers, but there's not really good evidence to support their use. And similarly, corrected calcium is pretty much useless as a screening tool because, as we've seen in the early slides, PTH maintains corrected calcium. In terms of radiology, I'll just quickly go through this. Basically, there's not enough evidence to use any of these as a screening tool, whether it be radiographs, quantitative ultrasound scan, which has kind of gone out of fashion, or even bone density scans. I know there's some papers that say bone density scans are kind of the gold standard in diagnosing metabolic bone disease of prematurity. I would argue that that is not the case because there's no good reference data in preterm infants. It's not particularly practical, but there's not really good evidence. But there is some anecdotal evidence to support that review of radiographs that have already been taken for other purposes may show features of metabolic bone disease of prematurity to aid diagnosis. So this is a preterm infant, I think it was 32 weeks of gestation, and you can see that there is a rib fracture here, but actually, and then when you look into the x-ray, you can see that there's good going evidence of rickets here. And the biochemistry was very much suggestive also of metabolic bone disease of prematurity, and this just adds to appreciating the severity of that. And then actually our radiologist looked at it and said, actually, no, there are extra rib fractures there as well that are more subtle. So finally, move on to treatment. So we've divided that into those that are primarily phosphopenic in their biochemistry and those that are calcipenic. So in phosphopenic infants, the biochemistry is of low phosphate or raised ALP or both, which is common to all forms of metabolic bone disease of prematurity, but with a normal PTH. And in those that are enterally fed, we would suggest to start phosphate supplementation. But in order to maintain the calcium to phosphate ratio, that we also start calcium supplementation, because otherwise, in our experience, all that happens by giving phosphate supplementation alone is that you drive a hyperparathyroidism. And key part of supplementation is to try, if possible, to give it separate to feeds, because otherwise the calcium and phosphate will just bind to the calcium and phosphorus that's in the feeds and not actually make any difference, as much of a difference to the child. It's difficult in practice if someone's on hourly or 2-hourly feeds, but I think it's important to bear in mind, and certainly separate to one another, because if you're giving both calcium and phosphate, they'll just bind together. In those that are PN dependent, it's much harder, and the suggestion from our group was to try and increase the phosphate concentration in the PN while still trying to maintain a reasonable calcium to phosphate ratio of at least 1:1. For the calcipenic state, so typically you would see a low phosphate or a raised ALP or both, along with an elevated PTH. So if they're enterally fed, you want to stop phosphate supplementation, because actually that will be making the situation worse if they're on it, and then start calcium supplementation. And similarly, if infants are dependent on PN, you want to provide increased calcium through the PN by trying to increase or optimize the molar ratio in the PN of calcium to phosphate. Now, people often ask me, do we not need to maintain the molar ratio that we spoke about, 1.3 is to 1, when they're calcipenic? And actually, the fact that they have got hyperparathyroidism makes that ratio less relevant, because that suggests that there is an overt calcium deficiency that needs correcting. And if you try and add phosphate into this situation, all that you'll do is worsen the situation. So this is from our paper a few years ago that summarizes the situation, where if you've got calcium deficiency, the body responds by increasing PTH, and we've seen already that the PTH causes bone resorption and osteopenia to try and maintain serum calcium levels. It also acts on the kidney to try and maintain serum calcium levels at the expense of phosphate, and it's the low phosphate that drives the rickets. If you just respond to that and give phosphate supplementation, unfortunately, all it'll do is bind to the calcium and reduce the ionized calcium, and so will actually make the PTH secretion worse. In terms of monitoring, it's fair to, throughout the treatment section, we've made it very clear that there is no good evidence. This is all consensus based. And similarly, monitoring, there is no good evidence about how often you should monitor once treatment is commenced. But we have suggested as a group to measure fortnightly, particularly the phosphate and PTH. The ALP, we've all seen in clinical practice, lags behind and may stay elevated for a lot longer, but you see more resolution in the phosphate and PTH acutely. And you'll either have responders, whereby the biochemistry normalizes, in whom you can start halving supplementation and stopping when you're on relatively small doses of less than 0.5 millimoles per kilo per day, accepting that some units consider a trial off treatment at about 36 weeks corrected gestational age, as one would think that hopefully you have remineralized the undermineralized bone by then. And then the other pathway is those that don't respond. So those that have biochemistry that is as bad as previously or even worse. So in these situations, if the PTH is raised, that suggests that one is not getting on top of the calcium deficiency. And so you need to keep increasing the calcium in increments with a maximum dose that we've suggested of 3 millimoles per kilo per day. Or if the PTH is normal, but the biochemistry is worsening, that suggests that the body needs more phosphate. And so trying to increase phosphate along with calcium to maintain the calcium to phosphate ratio. And if there is still not response, then to discuss with specialists, whether it be pediatric endocrinologists or pediatricians with expertise in metabolic bone disease. In terms of treatment, vitamin D deficiency, actually, there's quite a bit of evidence for, which I hadn't appreciated until doing this framework. In terms of values to aim for, as per kind of consensus, global consensus recommendations, we suggest aiming for a 25 hydroxyvitamin D of greater than 50. And if the child is deficient, then to give a treatment dose of vitamin D as 1,000 units daily with a combination of multivitamins such as Abidec and Dalavet and additional cholecalciferol alone. Now, it's important not to monitor this as frequently as the other biochemistry measures because it takes time to replenish your body store of vitamin D. And so I would argue that it shouldn't be done any more frequently than 12 weekly, but if it is, no more than 6 weekly, because otherwise you'll end up just increasing the doses of vitamin D because you're just not seeing that resolution to the body store of vitamin D. When you're monitoring like this, higher doses may be needed, and it's not unusual for some of our babies within this region to need 3,000 units daily, or if there are absorption issues, to give IM doses. And once you've got vitamin D sufficiency, then you can just reduce to the maintenance dose of 400 units. If I've got time, Mo, can I just quickly speak about some of the background? So why is this important? There's good evidence to show that metabolic bone disease of prematurity is associated with poorer respiratory outcomes. And that makes sense. If your ribs are weaker, that you're not going to have adequate respiratory support from them. From my perspective, we often get called about infants that have been discharged from the neonatal unit or whilst they're on the neonatal unit who have had metabolic bone disease of prematurity that hasn't been identified or hasn't been treated adequately, because it can lead to pathological fractures, typically either of the long bones or of the ribs, and they can present with swelling, deformity, and pain on handling. And we often then get asked for an opinion from a safeguarding perspective. So this is a child that came to a DGH with bronchiolitis, one of twins x 30 weeks. With this rib fracture. And the question was, well, they were on the neonatal unit previously, I think now about 2 or 3 months corrected gestation. Could this be because of metabolic bone disease of prematurity? Now, thankfully, there had been screening done that had shown no real good going evidence of metabolic bone disease of prematurity, which made things much clearer in terms of saying this is unlikely to be metabolic bone disease of prematurity and NAI needs to be considered. And so if we can treat these adequately, we can hopefully avoid such cases. And if they're screened appropriately, then we can have a lot more clarity on those babies that do develop metabolic bone disease of prematurity and therefore at a higher risk of pathological fractures. Unfortunately, there is no good evidence on what happens in the long term to infants that have suffered from metabolic bone disease of prematurity compared to those that don't. There is some evidence to suggest possibly a reduced bone mineral content and bone mineral density, but actually that very quickly corrects itself. And by kind of term corrected to 6 months corrected, there is no difference. There is some weak evidence to suggest that those that had a higher ALP have poorer growth in the long term. But the key thing that we don't know is, does it increase the risk for fractures in the long term? i.e., is this having a long-term impact on their bone health? And there is no evidence whatsoever to answer that. So from the working group, we came up with areas that actually there is research that still needs to be done to answer some of the questions that I've put out there as consensus statements. One, what are the long-term and short-term outcomes in these children? And that would require kind of natural history studies, etc. A lot more information on the role of passive physical activity regimens, which is happening across the world, just not so much in the UK. When to do screening, which will again need natural history. What are the biochemical cutoffs? Because the ones we have based are based on the best available evidence, but it's still not completely clear what cutoffs we should be using. What causes a phosphopenic state? And I think using urinary phosphate excretion as a marker for figuring out why children develop phosphopenic metabolic bone disease of prematurity would be really interesting, because it's not quite known. You shouldn't really be deficient in it from your diet compared to calcium deficiency. You probably shouldn't be losing it from your urine. So it's still an unknown area. And what the optimal regimens are for treatment. Again, I've said this is all based on consensus at the moment, and it would need a large-scale multi-center study, which, you know, with Badger networks, etc., the UK is really primed to do, to figure out what would be the best treatment regimens to address metabolic bone disease of prematurity. And finally, precisely what kind of a role does vitamin D play specifically in the context of preterm bone health? That's it from me. Thank you for listening. I'm happy to take any questions now. Just as a plea, when the BAPM framework does eventually come out, again, I'm crossing my fingers, please do comment. There's been a lot of people that have put a lot of work into this. And in particular, there'll be a lot of stuff there that some people disagree with. Please comment on that and why, but also please comment on what stuff you agree with, because otherwise we'll just end up with lots of conflicting things, rather than people commenting on what actually is useful for clinical practice as well that we have suggested. So feedback, positive and negative, would be very much appreciated. Thank you very much.
Thank you so much for that. That was really, really fascinating, and I'm waiting with bated breath for the framework to come out to have a look at it. I think I'm just going to kick off quickly with one question. I might have a vested interest. If you were developing a standardized concentrated PN bag, for instance, I just wondered, you know, you've obviously talked a little bit about the ratios, and you talked a bit about the sort of the evidence for the enteral sort of ratios. I just wondered what ratio or what amounts would you put into a standardized bag that you were designing for a large population of preterm babies?
Yeah, I mean, I can comment on the ratios. The amounts are a bit difficult to comment on, because I honestly, it's a bit of a different world to me. And if there are any pharmacists on here, then they can comment on how much we can feasibly get in without it all precipitating out, which I understand is the limitation. But ideally, I think the ratios should be very similar to what they are in the enteral state, as 1.2 to 1.3 to 1 in terms on a molar basis. And I think it's really important to kind of stress, which I don't think I did in the talk, that a lot of confusion is caused when you look at milligrams as a ratio, because then people because the molar ratio of phosphate and phosphorus is different and stuff. So I'm going to stick to millimoles and say 1.2 to 1.3, because even kind of parenterally, that seems to be a ratio that works for preterm bones. I know most of the evidence is in relation to absorption of calcium and phosphate from the gut, but even parenterally, going intravenously, that ratio seems to work. As a minimum, we have said 1 to 1. I know some of the guidance says 0.8 to try and prevent initial hypocalcemia. I tend to find that when the units around our area use those kind of ratios, you're more likely to get calls about metabolic bone disease of prematurity. So at the very least 1 to 1, and a bit more if there is significant risk factors for metabolic bone disease of prematurity. Hopefully that answers things.
Yeah, it does. Thank you very much. Mo, I'm not seeing any other questions. Does anybody else have any questions for Amish?
Hi, Takir here. I work at St. George's Hospital. One particular population that I found very challenging to manage in terms of metabolic bone disease is our surgical cohort. Babies with stoma who haven't achieved enteral autonomy and are stuck in volumes of 80 to 100 mL per kilo of feed with PN being piggybacked. The moment I try and correct their bone health, their stoma losses go up. The moment I try and optimize that within PN, the PN nutritional content drops, especially the amino acids, because the bag becomes unstable. So it's kind of no-win situation for this population. I don't know whether what your experience has been.
Yeah, not much more positive than what you've said, Tukir. Yeah, it is really tricky with the surgical ones. We, because most of them within the region would come to us because we have the surgical capacity here as well. A lot of them we try to kind of do bespoke PN, and again, I'm not quite sure what kind of magic the pharmacists do, but that helps to an extent. Trying to kind of replace things enterally in those that aren't absorbing particularly well, it becomes really tricky, and so they tend to kind of try and do different things with the PN. We have had, in some instances, having like a sidearm of calcium going through so that it doesn't disturb with the PN, but that, again, not all places will have the capacity to run a sidearm of additional calcium separate to the PN. In kind of some scenarios, we've suggested that. But beyond that, it is tricky because you're so kind of dependent on that PN.
Because there have been, we've got a fellow from Australia who was telling me about a more compatible phosphate source within PN that they have started using. I was wondering whether there was any discussions from our side as well.
Within the PN, sorry, Tukir.
Within the PN, yeah.
Okay, fine. That would be interesting to hear about. No, I've not heard of that.
We've got a question from Kate.
It wasn't actually a question. It was a comment on the back of Tukir saying about the long-term patients on PN. I don't have a solution necessarily for the calcium and phosphate, but certainly if we've seen infants with low vitamin D, and I think you've done this as well, Zoe, is actually to give buccal vitamin D to long-term patients who are unable to tolerate enteral vitamin D, and we've had some quite good outcomes with that. And that was actually on the back of what you do, Zoe. So we pinched your idea, and actually it does seem to have worked quite well with our surgical cohort.
We've had quite a lot of success with it. I think Venetia, I don't know whether she's still on the call, but we're certainly, I think we need to get it written up. We have been given buccal vitamin D even to babies who were managing for significant surgical NEC, and it seems to be well tolerated, and it certainly seems to improve their vitamin D levels.
Sorry, and what's the regime that you use for that in terms of dosing?
So we divide it up into 3 doses and give, I think, 200 units, which is about 0.1 of a mil. So it's a very easy amount to give buccally 3 times a day. Okay, well, so you can do it sort of with mouth care.
Yeah, it would be. Yeah, I would encourage that gets written up, because then that's kind of more evidence for that. Because like I said, I tend to, for those that have significant enteral absorption issues, suggest IM vitamin D, which is obviously not as nice. We tend to give it as kind of a slightly bigger dose, so we don't have to give it as often, but a buccal thing would be much nicer for the baby. Yeah,
no, it does seem to be well tolerated. Does anybody else have any further questions?
There is one in the chat from Venetia. She is on the call. She said she left a comment saying that pharmacy always works well with millimoles, and stability depends on the volume and the type of salt, the use of IV organic phosphate. So I think it depends on the phosphate salt that's used. And then there's a question from Claire Kane. She says, thank you so much, very clear. Is there a summary flowchart diagram in the framework that we can display widely?
Yeah. So that's one of the really helpful kind of suggestions that came from BAPM. We had done some summary flowcharts, but we've kind of now amalgamated it all into one all-encompassing flowchart, because I think some of the feedback from BAPM was that actually what people want is this summary that will be the kind of main go-to thing, and then those that want a bit more detail will come at it afterwards. So yes, there will be kind of a summary flowchart that should encompass most things.
Got a question from Sean as well.
Thanks, Zoe. It's more an observation really about Amish recommending calcium sidearms. We have strongly recommended not to do that in our SCAMP guidance, because we have concerns about it causing precipitation with our SCAMP bag. So please don't do that unless you're prepared to risk your IV lines, which most places are not.
I think that was one thing I was wondering about, because I'm always very hesitant to give anything with calcium in it peripherally, because it can really damage your veins, and often our babies only have a single lumen line. So you would need to run it concurrently with PN, and then obviously that's going to cause precipitation problems.
So we've done it in the double lumen ones. It's not something that we kind of go to as our first line. It's very much our last line in those in whom the metabolic bone disease of prematurity is continuing to get worse. But obviously we just like everyone else wouldn't suggest giving it peripherally because it's so toxic to the veins. That's only if we've got the capacity to be able to do so.
Yeah, Venetia's left another comment, which I think tied into this. It may have something to do with the amino acid source. So she says it's difficult to add lots of calcium with primine. You can maintain the protein, but not the calcium. But if you use Verminolact, you lose the protein, but you get the calcium in. And we use primine in our SCAMP bag. So,
is there going to be a parent information leaflet or anything like that that then comes out with the framework? Is that
yes?
plan?
Yeah. So and I'm sure Mo can tell you more about it as she contributed to that part. Yes, there'll be a we were quite keen to do something for the parents, because for them to kind of appreciate what this involves, but then at the same time not get too stressed and scared about this child potentially fracturing with any form of handling. So it was just to kind of empower the parents, one, so that they understand why the tests are being done and the medications that are being given, but also to empower the parents to be able to still continue to handle their children, just with kind of precautions to try and minimize the risk of fractures. So there'll be a parent information sheet that's built into the framework that can be used by units.
Right, that sounds good. I did have another question, but I think you sort of answered it really at the end, because I always sort of tell parents that these babies, their fractures, if they unfortunately get them, then they heal well. But I suppose I wondered, about the longer term sort of outcomes for these babies that have had significant metabolic bone disease, even if they haven't had fractures. But it sounds like that's an area that needs a little bit more research.
It's just something that we don't know. I mean, there's been stuff done by a group within the UK that had kind of followed up those that had a high ALP, which is kind of not an ideal marker but it's a marker, and they had poorer growth, and that's all we have. There's been some bone density work that's kind of conflicting, but in terms of their long-term bone health, their long-term fractures, there's nothing. It's a complete black hole.
Okay, I think, have we got any more, Mo?
Yeah, there's one from Kelly Watson. She says, thank you for an excellent talk. I'm looking forward to the BAPM guideline. I think clear diagnostic cutoffs would be helpful in clinical practice. We've noticed that metabolic bone disease of prematurity isn't always added to the infant's problem list unless they have a fracture. This means any interrogation of our EPR system for research purposes wouldn't identify all babies with metabolic bone disease. I think it also speaks to what you were saying around, safeguarding as well. If it's not in the history, that might be a bit of an issue.
Yeah, that's a good point.
I think that probably wraps up our webinar for today. So I think a huge thank you to Mo for all her organisation and everybody who's spoken. Thank you for giving your time, and thank you everybody for your interest and your comments and your questions. It's really fantastic to get such a good buy-in for the webinar. And again, just to plug the London Nutrition Group, we're keen to have members and especially representation from the MDT for these units that we have listed where we don't have representation currently. Please do come and join us. It's a really interesting group, and there's a lot to learn, and it's not too onerous. Mo, any final comments from you?
Just to say that all of you who registered on MedTribe, you should be getting in about 10 minutes an email with a feedback survey.